Good afternoon. My name is Goran Stankovic. I'm an international cardiologist from Belgrade, Serbia, and it's a pleasure to discuss with you today second webinar dedicated to bifurcation PCI. Last time we discussed provisional sidebrain stenting strategy, and our topic today is how to select and perform upfront two-stent strategy. So learning objectives for our webinars are in general to exchange and discuss contemporary treatment strategies using the visible heart content and to reflect on everyday practical cases. Specifically today, we try to understand when in our real life a two-stent strategy should be selected. Then we will have opportunity to discuss and to learn tips and tricks of double kissing tap stenting, and of course to discuss how to solve technical difficulties at each step of the procedure. Visible heart is procedure simulation in a beating heart, and we have possibility to use swine card, which is perfused, and we use angioscopy as well as other multimodality imaging like OCT, MSCT, which allows us really to study directly from inside different bifurcation stenting techniques, looking at stent and vessel wall interaction. It helped us a lot in the previous years to improve our technique. And last time we discussed the details of provisional side branch stenting strategy. Today we discuss upfront planned strategy, and I'll just start by saying that the last consensus document from the European Bifurcation Club says that elective two-stent strategies may be considered for important side branches with complex or extensive stenosis, with difficult side branch access, or high risk of side branch compromise. However, stenting technique should depend on individual patient anatomical characteristics and operator experience and skill. According to European Bifurcation Club, there is algorithm that we suggest based on the estimated risk of losing the side branch. If estimated risk of losing the side branch following main vessel stenting is low, then we go standard provisional, and then we stent across the side branch, we do, and then we decide, we do either tap, T, or culotte stenting. However, in case that we expect high risk of losing the side branch following main branch stenting, one option for experienced operators is to start directly with double kissing crush. The other option is to do inverted provisional, which means stenting from the main vessel into the side branch, and again do pot, distal main branch rewiring, main branch dilatation, and then we finalize again with T, tap, or inverted culotte. Here is schematic presentation of double kissing crush. You can see the steps. After pre-dilatation of both branches, we position stent into the side branch, optimally deployed, and then we do proximal. Following proximal optimization, we do first kissing balloon inflation, and after that, stenting of the main branch, proximal optimization again, second kissing balloon inflation after sequential balloon inflation, and we finalize procedure with final pot. And here you can see sort of simulation which shows you stent coverage with some malaposition in both sides, and of course what we see is two different diameters inside the main vessel stent, with larger diameter proximally and shorter, smaller diameter distally. And we can see also crushed segment outside of the vessel. Second technique, which is also standard today, is tap stenting. It's more for bifurcations with close to 90-degree ostium for the left main, After predilatation, we stent across. Then we do proximal optimization. And after proximal optimization, pull back maneuver to rewire. We do kissing balloon inflation. And after kissing balloon inflation, we position stent into the circumflex with balloon which is non-inflated into the LAD. And then we do kissing balloon inflation and final proximal apposition. So these are two techniques that are most frequently utilized today. And it's my pleasure to discuss with you tips and tricks of each of those techniques. You see, one of the major limitations of TAP is this small metallic neocarina. And if we are able to cover the ostium of the side branch, we try to do everything to minimize the length of the metallic neocarina. The program outline. So following these introductory notes, we will start with the first clinical case. We have great faculty today, and it's pleasure for me to have two colleagues and friends to discuss double kissing crush with Dr. Mirvat Alasnag, and then second case will be TAP technique with Jose de la Torre Hernandez. So great experienced operators, please use the chat box to put your questions as of now. We will be happy to address your questions and to discuss with you tips and tricks. So Mirvat, please, floor is yours, and thank you very much for joining us.
Thank you, Professor Stankovic, and thank you to Rutherford Medicine for organizing this. So the purpose of this presentation is really to go over the different steps of the DK crush and to kind of see how we can embrace the this new technique with the technology that we have. So this is an 88-year-old gentleman. He has multiple cardiovascular risk factors: diabetes, hypertension, hyperlipidemia. He also has many comorbidities, including COPD, advanced osteoarthritis that has limited his mobility significantly, and he has complete heart block for which he is pacemaker dependent. He presented to our hospital with an acute coronary syndrome. His physical examination, he was hemodynamically stable and euvolemic. The initial workup, his labs, CBCs, and renal function were actually normal. His echocardiogram, he had mild LV dysfunction, but overall a preserved LV systolic function with ejection fraction of 45%, grade 2 diastolic dysfunction, and only mild to moderate degenerative mitral regurgitation. Even before we took him to the catheterization heart team meeting, and given his age, very limited mobility, advanced COPD, and I actually don't have it on the slide here, he has unilateral completely occluded carotid. The surgeons deemed him too high risk for any bypass surgery. And I think if we look at the body of evidence that we have about, the Syntax trial and so on, an Excel trial, this particular age group was actually not really investigated, and so it's not applicable to them. And that allows us to focus on the procedure itself and the technique itself. So we went ahead and did an angiogram for this gentleman. This was a radial 7 French sheath and EBU guide. You can see both angiograms over here. On the left of the screen, you see an areocaudal view that shows a left main that is distally tapered and significantly diseased. There's a mid-circumflex lesion after the AV groove branch, and you see diffuse disease of the LAD as well. Obviously not very well appreciated in the caudal views. But at this point in time, it was important to stop, talk to the patient and the family, and explain to them that surgery is not an option and we need to proceed with something else, which is complex multivessel PCI. The views that you see in front of you now, this is the areocranial. Again, you see moderate disease of the left anterior descending artery, but very long segment of disease. What we ended up doing is wiring both vessels. We elected to just do a focal stenting of the mid-circumflex, which you can see on the screen in the right hand. The normal pre-dilatation stent, post-dilatation. We tried to stay away from the bifurcation. In the previous picture, you could see that there was a clear touchdown. There was a normal segment after the branch. So we kept that as least complex as possible. And afterwards, we figured, this is an old important to do OCT for him and see how much debulking or atherectomy and how involved this process was going to be. So to my pleasant surprise, when we did the LAD, there was minimal calcification. And so we ruled out any role for atherectomy devices and debulking in this patient. We went ahead, as you can see from the top screen, we did pre-dilatation. The lesion yielded very nicely. We went with one long stent in this patient, post-dilated, and we wanted to give ourselves enough room proximal to the stent to be able to perform a bifurcation strategy. Now, if you see here, the OCT, the left main reference diameter was about 4.2, LAD about 3.3, circumflex about 3.0. And if you look at the OCT itself, what you see in the middle picture is we're looking at the ostium of the circumflex. It was also diseased, and it was a bit challenging to think tap, either you have a or you end up with a neocarina protruding, and the proximal circumflex was also diseased. So we elected to go ahead and do a DK crush in this patient. So at this point, go ahead.
Can I stop you at this point and just discuss a little bit anatomy with Jose? And is Jose something that you would also elect two-stent strategy as upfront plan because of high risk of losing the circumflex in this case? What would be your strategy and your approach?
I agree with Mirvat that you need imaging, intravascular imaging, to check the ostium and LAD and particularly circumflex, to see how is the involvement of disease at this point. The circumflex is a big vessel. You implant the stent there, then it's a vessel that you need access in the future, maybe a restenosis progression. And the ostium, I didn't see the lumen of the circumflex, but it's a bit narrow, and there is plaque. Then I am concerned. Maybe you can start with a provisional, but keeping in mind that maybe you are ending up with two stents. But then I see reasonable to start with an upfront two-stent strategy.
Yeah. Mirvat, can you share with us in your everyday practice? I know that you really like to perform and you have a lot of experience with double kissing crush. But is this, in this specific case, the first choice because of specific anatomical characteristics, or it's just safety to preserve circumflex and then focus on the crossover stenting towards the LAD?
So, as Dr. De La Torre said, initially you would just want to, it's a large circumflex, you do want to protect the circumflex artery in this patient. And in an 88-year-old, I want to be as minimalistic as I can be. So if I can get away with provisional stenting, I would much prefer to do that. I think once we actually wired the circumflex and started intervening on the mid-circumflex, it became abundantly obvious that that proximal lesion was, or the ostium was actually tighter than what we thought. And so it was a change in strategy. But in addition to that, one thing I have learned, even from this particular case, that intracoronary imaging really does help guide you and really does help you sometimes change your strategy. When I went in thinking this is an 80-year-old plus man, we actually had our rotablator standby, and we decided to do imaging first. We didn't need the rotablator. The imaging clearly showed us, despite being over 80, he did not have enough calcification to justify rotablator up front. And so that was a change in strategy based on imaging.
Yeah, thanks. If I try to interpret for myself this spider view, impression that most of the plaque is actually in front of the ostium of the circ, and that precludes crossover as the first choice, because I'm afraid that plaque shift and carina shift may compromise that circumflex. So I would do probably the same, and maybe slightly different in the way that I will start stenting from the left main into the circ, but these are all variations which are based on operator skill and personal preference. So if you can now lead us through the steps of double kissing crush, I think that will give new tips and tricks, but also topics for questions and for discussion.
So we, at this point, have wires down both the LAD and the circumflex. We're dilating, as you can see on the right-hand side, dilating the proximal circumflex coronary artery. In the next view over here of the top screen, you back into the left main. The bottom picture is just a fluorosafe. So sometimes with long procedures, you can't cine everything and you need to be conscious of how much radiation there is. But effectively, we're dilating into the LAD itself. And then what we're doing is we're trying to position the stent. What we were doing when we're positioning the stent is you can see there's a distal stent in the circumflex, and we want to make sure enough of the ostium is covered into the left main, not with too much protrusion. So we're talking about 2 to 3 millimeters. So I think spending a bit of time in this step is very important for positioning. We don't want to convert the mid-circumflex and jailing that AV groove branch. And at the same time, we don't want to be too proximal into the left main. Once we're happy with the position of that stent, we still have to make sure that often when I do position, I try to make sure that my balloon that is across the left main into the LAD is there as well. Because your position can actually shift, and we are talking about 2 to 3 millimeters. So the next picture, you can see we're deploying the stent itself, and you can see that we managed to get the ostium at this point in time. We go ahead and post-dilate in the still frame that's on the right-hand side. So we're doing our conventional post-dilatation, just like any stent that you have just deployed. And after that, we pull the wire back. Everything comes out from the circumflex system. The balloon that was across the circumflex in the left main into the LAD is now inflated to do our crush. And, you know, initially when I first started doing these procedures, I was afraid of the crush. But eventually I learned the crush is actually my friend. The better the crush is, the more appropriately sized balloon, the easier it is to cross back into the vessel that we want. And so this is actually from from the Visible Heart Laboratory. And you can see over here inflations. So if you're not appropriately sized, it becomes very difficult. So this is, they're doing their first crush. And after they dilated, you can see how crushed it is. But then they're going to come back and crush one more time because they realized that the stent was not adequately crushed. And so it is important to have an appropriately sized balloon to do the crush, because it actually facilitates recrossing the second time around. And you can see in the picture over here now. So this is the visible heart. You see the wire in the LAD here, and the diagonal is what they were actually crushing. And then they're going to show you a picture from within. And when you look at the picture within, you see that it still needs more crushing. So they do take a second balloon. They're going to go ahead and inflate the balloon at this point in time. And then once you see the balloon, the second crush go in, this time with a 4.0 balloon, the first one was a 3.5, as you can see labeled, you see a much better crush happening in this stent. Go to the next slide. If I go to the next slide, after we do that, you see over here, as they're wiring, that the wiring is actually a lot easier. And the wiring, you should go down the main vessel itself first, so LAD in this case, and then they're pulling back and trying to recross into the diagonal branch. So initially they're going distally, but then they want to come back into the middle cell, and that's what they end up doing. And once you've crushed that stent, it becomes easier to navigate and go into that vessel. And that is in fact what happened. So you see our wire, we just went down the LAD, turned the wire back, and we're able to cross again. I don't know what your preferences are in terms of recrossing wires. I think when you do an adequate crush, we usually go with our workhorse wire BMW. When I have difficulty, I try a Pilot 50, for example.
Yeah, Mirvat, can I stop you again at this point? I think there are two important topics to discuss. We have a question from one of our participants, why you selected OCT instead of IVUS. Is there any specific reason to do imaging with OCT in this case?
So, you know, I'm not an expert in OCT, but OCT gives you depth. So if you're actually planning some kind of atherectomy, it helps you determine how deep your calcium is and to determine which atherectomy device you want to go with. And that's really why. I know there are some centers that are more comfortable with IVUS, and our center, we actually do more IVUS than OCT. So I'm more IVUS trained than OCT trained, to be honest. But as I said, we usually do it when we're looking for calcification and how deep that calcium is.
Especially because you used OCT imaging to evaluate the whole coronary tree. It was not just to evaluate left main. Jose, do you want to comment on that?
Exactly. OCT in this case is not is a proper are going to evaluating the whole LAD, the circ, and also you can use it for distal lead veins. So the peroneal depositing lead vein is when the lesion is more proximal, or or you have a very large lead vein. And the contrast, of course, you need more contrast. You cannot see the full picture of the vessel. Then for the sizing, is also some problem in the lead vein, but it's okay. You can use it. If this technique you feel comfortable, it's okay.
Yeah. Second question is, why not provisional? How much osteal involvement of branch vessel should warrant upfront two-stent technique on IVUS or OCT? Any specific criteria, or it's just diffuse plaque distribution and unfavorable access, so the risk of losing was high?
It's actually exactly what you said. The access is unfavorable, but the surprisingly, by naked eye, the ostium was not very clear to be involved, but once we put that OCT catheter, it was fairly clear the ostium was involved.
Yeah, and what is the size of balloon used for crushing? You already explained, but I think it's important that if you select balloon according to distal main vessel, according to LAD, in that case, of course, because of step down inside the left main, you will not be able to fully crush the stent from the circ, and you clearly show that undersized balloon does not really do work. So there is a risk that you can re-enter through the true lumen of the stent. And this is what I also try to insert in video animation, that we actually do sort of pot maneuver, taking bigger balloon according to the size of the left main. So to answer the question on the sizing, we should do probably two-step crush. One is adequately sized balloon, as you said, according to distal main vessel, and then bigger balloon to fully crush main. I think this is important, and I think this is something that we should share with people, and we should share our regular practice. So you did crush with the bigger balloon, or you use the same balloon, higher pressure with the proximal position?
No, we take, whatever I would normally pot with is what we usually take to crush. So
you use two balloons according to appropriate suggestion from the European Bifurcation Club. Excellent. Please continue now. For now, I think we have clear answers to all the questions that we got so far.
So then what you see is we were able to recross into the circumflex.
Sorry, Mirvat, there is a question, proximal or distal recrossing. I'm sorry, because there are so many questions coming. Definitely your case is very interesting. So you said central or proximal. I agree with you completely. This is because in crush, you actually push your stent and you create small gap during the crush. So it's dangerous if you try to cross distally. And the only technique that we should try to cross proximally is actually double kissing crush or any crush variation. Okay, please continue.
Right. So then what we do is we open the cells with the smaller balloon, as you can see in the top image. And then we take a bigger, more appropriately sized balloon for the actual kissing. And for the kissing, you don't need to be terribly into the left main at this point, but you do need to make sure you're covering both segments. And so the bottom is actually showing the kissing in both the LAD and the circumflex artery. So at this point, now we've removed everything from the circumflex again. So we are done with our first crush. We're done with our first, we're moving on to the second crush. So at this point, we're trying to position our stent, and I think we need to utilize everything that we can. And just going back to what I was saying, that there is quite a bit of radiation involved in these long procedures. We use clear stent or stent boost over here. We want to make sure distally we're overlapped, and then we come back proximally. We want to make sure we're covering the entire segment of disease in the LAD back to the left main. And on your right hand, you can see the crushed stent in the circumflex and the still frame over there. So at this point, again, we use clear stent to help us position our pot balloon. So you want to be at the ostium of the stent. You want to determine where your carina is, where the stent in the circumflex takes off. You want to position your stent, your balloon, I'm sorry, which is a non-compliant balloon. And usually one thing that I've learned over time, and I don't know if all labs have all supplies, but before you start a procedure like this, just make sure you have all the and all the lengths that you need. So make sure you have if this is a 4-5 balloon, which it was a 4-5 balloon for the proximal optimization, make sure you have the 4.5 by 8. If not, then you want your stent to be going all the way to the ostium, so you can hang a balloon, for example, if what you have on the shelf is 4-5-15, and hang it a little bit into the aorta, but just so that you preserve your carina and you make sure you're actually doing your post-dilatation appropriately. So this is, we're doing our proximal optimization right now, which is a step that's added. It used to not be this kind of a step. Again, I've already moved on. Here you can see the wire actually becomes much easier when you're doing your proximal optimization. You're not sliding under any kind of strut. And at the same time, it opens up your path into the circumflex and into that bend that you need. So this is again coming from the Visible Heart Laboratory. And again, it shows the crossing. This is what Dr. Stankovic was telling us just a few moments ago when there was a question about where to cross. So this clearly shows where it is being crossed. They're actually first, so this is the angiogram. You're seeing the wire in the LAD, the diagonal. So they actually end up coming back, I believe, and then re-entering more centrally. There you go, you're going to see it now in a second. They enter more centrally into this vessel. So at this point, we continue with our ballooning. We do the high pressure dilatation of the LAD. We are doing our dilatation across into the left main. The first image that you have on the left side, this is the kissing inflation that's in the LAD. We've recrossed into the circumflex. We're kissing right now. Again, we're positioning our balloon for an appropriate proximal optimization, and then we're inflating. What you end up having is, this is the LAD after we had stented it, and the final image on the right hand, you see all the vessels are actually preserved, and unfortunately I did not do a post-procedure OCT, which ideally we should have done, but an 88-year-old man was starting to get cranky after all this time, and we just had to move on, to be honest.
Yeah, bravo, Mirvat, really beautiful.
Excellent.
Excellent angiographic result. Before switching to Jose, there are a few more questions I think we should clarify. There is a question for you, Mirvat, whether you were thinking of using mechanical support in this case or was not necessary?
So no, we are very selective in our mechanical support. This was not the last remaining vessel. The LV function was well preserved. The patient was not in pulmonary edema. The EDP was not abnormal. It was euvolemic, ejection fraction of 45%. Granted, it was a long procedure, and my only concern in these 80-plus-year-old gentlemen or women is usually they just start from their osteoarthritis and everything. They just start to get very impatient and restless on a table. And so sometimes just having an anesthetist to give you slightly deeper sedation so you can continue safely is all you really need. But no, I would not use circulatory support in somebody with an ejection fraction of 45.
Excellent. Thanks. I fully agree. I don't need to repeat. We agree 100%. Again for Mirvat, does the angle of bifurcation influences selection of two-stent technique, or other considerations come first?
So the angle is very important, yes. So if it was a 90-degree angle, and then I would consider a tap technique in these patients. But I think most of the panelists or the faculty that we have today as well, if we don't feel we need a two-stent strategy, then provisional really is the way to go with the majority of our cases. We don't insist on an upfront two-stent strategy. But as I said here, what changed things was actually the OCT.
Excellent. For a long time we are discussing, we encourage use of imaging, especially for left main PCI. But whenever we present at big meetings, it's not so frequently done in real life cases. And I'm really glad that today both our faculty are using imaging, and it's a privilege to learn from both of you. Mirvat, final question for you is related to diameter of balloons for kissing. Are you using balloons according to distal diameter of the vessel, or you decrease by 0.5 millimeter?
No, we still use the reference diameter, the distal reference diameter high pressures. We use intermediate pressures for the kissing inflation. It's really the pot or the proximal optimization where we actually go higher in terms of millimeter diameter, and we go higher in terms of atmospheres as well.
Yeah, more comment than question. If the second time rewiring of the circ is through the proximal cell, there is more metallic neocarina. I think it may be better to rewire circumflex middle distal, which reduces the amount of metal carina. What do you think about that?
Well, you just commented on it. So distal is probably not, and in DK crush, it's probably the only time we would be willing to go more proximal for this, simply because of where we're pushing the struts that we've crushed.
Yeah, question about
created.
Yeah, I'm really sorry because we keep receiving the question, and I'm glad that people like our case so far, and happy to discuss. What do you think about mini kissing, and when would you indicate mini kissing? I think it's just short non-compliant balloons with minimal proximal overlap in the polygon of confluence, and it's not when. I would suggest every time. If you don't go too much proximal with the overlap, you don't deform the stent in the proximal segment. So I think makes procedure easier and more successful. Mirvat, thank you so much. Wonderful case, wonderful. I saw it on Twitter, just I saw that you promoted, and thank you very much for doing that.
Thank you.
So next case comes from Spain. Jose, good friend of mine, but real world expert for left main IVUS guided procedures. We learned from Litro many important data, and I'm happy that you accepted our invitation to join. So please present your case, and then we continue discussion.
Okay, thank you, Goran. It's a pleasure to be with you, with Mirvat. Just one question, Mirvat. Do you think that any stent is suitable for the DK crash? Do you think that there are differences between platforms? Is any stent?
Subtle differences in the platforms that are used. I think, again, you need to know what your cath lab carries and what diameters and so on. And you need to see how far they expand. So, you know, for example, the Onyx stent is actually very expandable in it. And if you don't have, if there's too much of a size discrepancy between the left main and the LAD, for example, what you can do is, you know, start, for example, with a 3.0 for the LAD, but then really post-dilated to a 4.5 once you're in the left main.
Okay, thank you. Then we're going to move to my case. My case is much more simple from the perspective of the technique because you are going to see between provisional and upfront two-stent techniques. And the case is a 70 years old male with high blood pressure and high cholesterol with COPD class 2, presenting with stable angina in class 2, but with progression in lax 2 weeks. The stress echocardiography showed normal ejection fraction, but signs of ischemia, potential ischemia in the anterior and lateral segments. In the angiography, to start with, you don't see nothing really severe or very remarkable, but did you pay attention to the distal lead main, you can appreciate that there is a narrowing in the distal lead main and also in the ostial circ and ostial LAD. There is narrowing, there is an stenosis there. From the AP cranial, you see the difference in caliber in the lead main, and particularly you see that the distal lead main is even smaller than the proximal LAD, which is really suspicious. We did several projections. These are the steel frames. It was a distal lead main lesion of ambiguous severity with both osteon involved with moderate stenosis. In the right coronary artery, nothing significant. And it's our strategy in these cases because we have ambiguous, not clearly severe stenosis. Sorry, I cannot advance this now. We did IVUS in the lead main. As Goran said, we published a Litro study years ago, and we use lead main frequently in these cases. Lumen in the lead main is 5.5 with a large plaque, eccentric plaque, no calcified. And in LAD and CERC, we see also plaque more extensive in LAD with the lumen 3.8. And in circumflex, the plaque is moderate, is against the carina side, and it's 3.9 square millimeters. And we have borderline lumen for all these different sites. In this consensus document, I have the opportunity to participate concluded that in those cases with MLA between 5 and 6 or 4.56, I personally think between 5 and 6, like in this case, it was 5.5. We have to consider physiological assessment because MLA there is in between, is in the border, and we need some more additional information. In this case, FFR was really positive in the LAD, 0.7, and was negative, but borderline negative, 0.82 in circumflex. Then we have a patient with lead main disease, significant, and syntax score is 12, just 12, and the score, syntax score 2 is clearly pro-PCI, and the guidelines support PCI in this case, so we proceeded with that. The decision now is if to go provisional or not, to go with two-stents. In this case, we have several criteria. One of them is based on IBUS. We prefer provisional when the circumflex luminal area over 3.5 and plaque burden less than 50%. This is based on a study by our Korean colleagues that indicates that any lumen, baseline lumen less than 3.5, 3.7, is the risk of compromise after crossover stenting is higher. In our case, I remember was 2.9, then we are really in the borderline. Preference for two-stent technique is we have several angiographic data features or characteristics, but also an IBUS-based criteria, which is to have significant ostial circumflex disease with a lumen less than 3.5 and more than 50% plaque burden. There are others that are related with the failed provisional stenting, which is a residual stenosis, low flow, dissection, etc. In this case, we have this situation with circumflex in borderline lumen, borderline FFR, everything was in between the negative and the positive. Then we decided to go first with a provisional, but keeping in mind that the need of two stents would be really plausible. We sized the stent according to the proximal LAD, as we do always, and the stent was 3.522 from lead main to LAD. And then after that, we did pot. We also sized the pot according to the IBUS. You see the proximal lead main, which is 4.5 millimeters. So we have to do the pot with 4.5 in order to have a full opposed and expanded stent, as we can see on the right side, 11.4 square millimeters. But then the graphic result is not really nice. You see ostial pinching of the circumflex. We rewired the circ. We opened the struts with a small balloon, and then we did kissing. And despite the kissing, we did IBUS, and the lumen in the circumflex appears really compromised, as you can see in the IBUS imaging. If we compare the baseline with the post-stenting, the lumen just dropped from 4 to 2.9, which has been described in the literature that this happens. This is a Carina shift, and we cannot solve this problem with kissing. And then we have this situation with a small lumen insert. And because we have the pressure wire in the table, we did FFR insert and the jail insert, and is positive now. Of course, the baseline value is not predictive of the result. 0.82 was very close to the border. Then it's reasonable. It's understandable that now we have a positive result. Because the angulation between SIR and LAD was more than 60, 70 degrees, was closer to 90, we decided to do in this case a two-stent technique that could be the tap and no culotte. We prefer culotte when the angulation is closer, narrower, less than 60. This is the approach from the European Bifurcation Club. These documents are very, Goran, you cannot imagine how helpful has been these documents for many people, for fellows, for even for all attendants like me. I expect every year the document to see what is the consensus, what is the best, because the document is always very educational. It's looking for the simple, but also for the most effective and efficacy. And you can see here that when you have a jail side branch, the serving further intervention, as we did with dilatation and kissing, and the result is not good, you have to go to stenting of the circumflex, and you have different alternatives like tap, pull-up, or T-stenting. And in this case, we decided to go tap because of the angulation. This is how you have to proceed in these cases. You have the provisional stenting to LAD, then you implant the stent in the circ with some protrusion, with the balloon in the LAD, prepared for just pulling back the balloon in the circ to perform the kissing and finally the report have the good result. And this is what we did. First, a stance 3-14 in circumflex with just a small protrusion. We dilated, we did the kissing balloon, and finally the report with 4.5 millimeters. This is the angiographic result, which is a good angiographic result in this projection. We have also the spider with a very nice result. And we did IVUS, and here's the result with over 11 square millimeters in the left main, over 7 in LED, and over 6 in circumflex, with good polygonal confluence, good apposition, no problems in the distal stem edges. And the lumen is really, as you can see here, clearly over the threshold that has been suggested by the Korean people, but also by the Excel trial as indicative of a good result and lower risk of restenosis. This is an example from the Visible Heart Lab. I have the opportunity in 2017 with Paul Liacho. It's really amazing to see that. You understand many things that you are doing in the patients every day, just watching these cases and performing directly these cases. This is how to reshape the carina with the kissing balloon. The kissing was done with two balloons, 3.5 and 2.5. And after removing the balloons for the kissing, they are going to see how excellent is the result, the position of the carina, which is exactly symmetrical, is in the center with no shift to the circ with LED. You can see here how is the effect of the kissing in the case. The report is very important. You can see now the report to optimize the final result. Here is the report. We will see now that the report with a 4 millimeters balloon is done, and the balloon is retrieved. And you see the proximally, the stem and not elliptical and well opposed, well opposition, everything. That's the positive effect of the report, which is on one of the contributions of the European Bifurcation Club consensus documents to recommend all this sequence of a pod kissing report, which is essential for the two-stance techniques. Finally, you have this amazing result with just following these steps and using these onyx extents that are very geometrically and they are built for this kind of procedures. I published in JACC the intervention as some suggestion for the provisional stenting and how to proceed with compromised circumflex. This was a proposal of a study that was published in the journal. This is our criteria for optimization. We presented in early intervention this year. And this criteria you can use or not is for IVUS guided PCI. You just pay attention to different parts like full coverage. You see the stem edges proximally, the deformation, distally, the plaque burden, and the dissection or hematoma. And for expansion, we use the percentage of expansion with respect to the proximal reference lumen. If the stem is, the left main is tapered, then the 90% goes down to 80%. And we have similar criteria for LED and circ. This is really criteria that works because you can see here that our protocol was associated with the better outcomes compared to angiography or just a group of IVUS without any protocolized usage. So I've finalized my case telling you that left main PCI for distal lesions is most commonly performed with the provisional stent approach. This is absolutely true. The indication for two-stent technique can be established up front, for example, like in the Mirvat case, or after an optimal provisional stenting, like our case. The selection of two-stent technique should be based on the anatomy. This has been previously Goran perfectly. Is the anatomy, is the clinical evidences, and is the operators' skills and preference. The use of IVUS, some people prefer OCT. I prefer IVUS for left main, but OCT could be helpful. May help to plan, guide, and optimize the PCR results in this critical segment, which is the left main bifurcation, improving the clinical outcomes. Thank you.
Bravo, excellent presentation. I really enjoyed very much, and we received several questions, but I didn't want to interrupt you because first question is actually for both of you. Who should be performing these types of left main bifurcation procedure? Do we need senior operator and junior operator? What is the practice in your hospitals? Mirvat, maybe you can start first.
Yeah, so bifurcations, I did not do them independently when I started. When you come off I think you learn basics, you learn safety, you learn judgment. The bifurcations, for two reasons, I never did them on my own. One, the techniques themselves evolved significantly. So the DK crush, there's an extra pot that was added and so on. And the wiring skills and so on, you need experience. It isn't just the basic safety. So I actually started with Dr. Shabi, who's the director of our center, and he is the bifurcation guru in our part. And so I always paired up with him, and I tried to pair up with him whenever he had a bifurcation of any sort. So whether it was a tap or a culotte or what have you, until I felt comfortable enough with the different steps, because you can easily confuse the steps if you don't understand them, what comes first and where you cross and so on. So my personal advice is to pair up with somebody who's more experienced in terms of skill, but also in terms of judgment. Learn that really not every case needs upfront two-stent strategy, and when you can back off and it's safe to back off.
Yeah, thanks. In Spain?
Mirvat is right, I think, and it's really wise to think in that way. At least in my hospital, I think the young interventionalists or the fellows, they in the first 2-3 years, they don't do the PCI inlet main. They just, at least the elective cases, they just watch how to do the cases. They are with you doing the cases. But after 2-3 years, and because they have sometimes emergencies with lead main disease, they need to know how to fix this. Because sometimes they are called in the Saturday night and they have a patient with a lead main 99%, and they need to know. Then they start to do PCI in lead main in an elective setting, maybe 2-3 years after regular PCI. And then progressively, they learn the techniques, the imaging, the use of imaging. And as Mirvat said, not only that, but also the clinical judgment, because it's very important to have the head very, very clear, not only the hands.
Yeah, I agree with both of you. At least in my center, we always have one senior operator, whether he's directly scrubbed in the lab or he's just observing.
Yes, exactly.
But I think whoever does PCI feels much more comfortable if he can have a friend to exchange and discuss, especially critical steps of the procedure. For Jose, for you, question regarding use of imaging and physiology, which one you prefer to assess significance of the pinching of the side branch after main vessel stenting? So
yeah.
Would you decide to start with FFR like you did here, or imaging?
To be honest, I am a very imaging guy, but I do a lot of physiology as well. And for the pinching, I prefer physiology. I think it's better. Imaging sometimes is a problem to cross the jail vessel with an imaging catheter. You might maybe come in trouble for the entangling, or the catheter maybe can't trap it. Second, there is no clear threshold. What is the lumen of the circumflex that is really significant? I don't know. Then for the lead main assessment, okay, but for the circumflex, when it's jailed, I say physiology is better.
Yeah, if we can have your slides back, people like very much original image of the circumflex IVUS, and they would like to, if possible, ask you to recommend again on the plaque location in the left main and relation to risk of carina and plaque shift. I think it's very important because it's privileged to have a real expert so we can learn how to interpret pullback from circumflex.
I'm trying to go back here.
Yeah, slowly we are almost
yes.
there.
It's moving, it's moving. It's okay.
Only caveat with physiology is the wires are not as friendly for recrossing. That's the only, I think, drawback, and that's probably why operators don't do it more often.
Yeah, you're right. Sometimes
ready to recross.
The only solution sometimes is to cross with a very good wire and then to change the wire with a microcatheter or something like that, and then to do the FFR. But it's a bit tricky and time consuming. You're right. This is the problem with the pressure wire. This is the imaging of the circumflex, and you can see very baseline in the left, post-stenting in the lead main LED in the right. And you see both mechanisms that are the carina shift, but also you pay attention, the thickness of the plaque is different. In the circumflex, it's thicker in the right it's not only the sheath of the carina, because even with kissing, you cannot solve this, but it's also that the plaque in the circumflex is becoming like folded, thicker, maybe displaced, just like a snow plow. And then this larger accumulation of plaque in the circ and the carina sheath, in this case with the stent. Then the mechanism is many times mixed of both. And this has been published. You have the reference down in the slide that usually there is a loss of 1.5 square millimeters in the circ after crossover stenting. Then when you start with, that's why I say that when you start with 3.54 square millimeters in the circ, after crossover stenting, maybe you are in trouble, particularly when you have a large product burden. When you have over 4 to start with, it's safe to do provisional because the residual lumen is going to be enough.
Yeah, thank you. I think it's great. There are several questions on POT and KISS, POT, KISS, POT. When would you decide to use standard approach, POT, then kissing, and then final POT? And when would you elect to do POT, side branch balloon inflation, and re-POT proximally? Is there a difference in your practice, POT, KISS, POT versus POT, side branch inflation, POT?
Mirvat, or?
I mean,
Yeah, whoever wants to address.
Yeah.
There are two practices. Usually, old-fashioned way to do POT, then exchange wires, do kissing, and then final POT. There is a recent suggestion to make it simpler to do POT, side branch ballooning, and then re-POT without kissing.
Yeah.
So, what is your opinion, and when you select each of these?
This is totally true. Sometimes I do the simple POT, side branch POT, but usually when I have the clear information that the circumflex is not really affected or the angiographic result is really good. And I do the KISS inversion when there is some concern about the circumflex, about the presence of plaque, and the angiography there shows some mild moderate stenosis. If there is a moderate stenosis in the circ, maybe I do the KISS inversion, and I move to the simpler, just with side branch adaptation between POTs for those cases when the angiography of the osteon is better.
Yeah, advantage of POT, KISS, POT is actually by simultaneous inflation, you position carina in the center, which is very important for the flow pattern. So especially for big bifurcations like left main, I think POT, KISS, POT has some advantages. It's not documented, to be honest. We don't have clinical evidence for that. But based on bench testing, there is some advantage of removing struts and then positioning carina in the center for the shear stress pattern.
Also, the relevance of the circumflex when the vessel is very large, I think kissing is very important. If the circumflex is small, maybe you just can avoid the kissing. It depends on the vessel size.
Yeah, there is also. Sorry, Mirvat, please.
I think the more imaging we do with these bifurcations, the more I've learned the value of the POT, KISS, POT, that the KISS just helps align and centralize those two holes that we've just created. And so I'm doing it more, albeit no clinical data to suggest that you don't need it or you need it, but still.
Yeah. Another question is the position of POT balloon. Tricky, especially final POT. And I will comment after you also on the role of final POT, because I see that there is a lot of misinterpretation regarding the position of POT balloon. When you do POT, how you do it practically? What is your standard practice?
For me, just proximal to the carina, but very close to the carina. Because some people is doing, I don't know, is afraid of being inside the LED, and they just, it's not good to be just in the LED because you're not doing the pod, you're just ruining the pod. But the pod should be immediately proximal to the carina and just enough aggressive. I mean, with the eye, would you see how is the size of the lead main, for example? And sometimes if the stent is 3.5 and you need to go to 5, you go to 5 or to 5.5. You need to report to the proximal reference site. Yeah.
So you select POT to imaging.
To imaging, yeah.
Fantastic. Mirvat, what would you suggest?
So one is you need to know, again, what your vendor is, and you need to know where the dot of the balloon is. Some of them, there's a significant gap between the end of the balloon and the dot of the balloon itself. So where you position your dot, bear in mind that there's more balloon beyond it once you do a full inflation. And what we usually do is, what we try to do, at least in left main, is try to use stent boost or clear stent like I showed, and try to put the marker just at that carina, and then do the inflation.
Yeah, the more complex to explain and also to decide is the role of final pot, especially after tap. And because of the presence of metallic neocarina, people are discussing whether we should use. So in your practice, if you do T or tap, would you always finalize with pot, or you sometimes stop after kissing?
I usually end up always in left mains with pot for other reason, which is the proximal deformation of the stents, that sometimes, because you are continuously with the guiding catheter pushing the stent, the less action that you have to do in the left main is to do the pot, to accommodate the proximal and part of the stent to the aorto-ostial junction or the proximal part of the left main. It's not only the affair of the rest of the stent, but it's even to prevent all the deformation, and it's the last action you have to take in the left main, the last taken measure.
Yeah, so it's sort of final proximal.
Yes, final touch.
Yeah. You know, I wrote recently that we should distinguish between final pot, final proximal balloon inflation at the stent edge, because it's not exactly the same. When you say final pot, it's usually position of the balloon inside the stent to correct oval shape deformation created by kissing. And as you said, in left main, you try to finalize procedure with final proximal flaring, actually inflation outside, partially outside of the stent, in order to correct longitudinal stent deformation. So people mix these two interventions. In TAP, especially if angle is narrow, especially if you have a longer metallic neocarina, I think you should either avoid completely performing pot and just perform final proximal inflation, positioning balloon very proximal stent edge. If you have enough metallic area proximally in the main vessel. If you don't have, if it's short, then I think you should stop procedure after kissing. You should not finalize with pot. It's very dangerous because we have, from a Visible Heart Lab and also from the October study, we have evidence that position of the balloon for final pot should definitely be more proximal than position of the initial pot balloon. And sometimes in real life, with the rocking, it's not so easy to have stable balloon position. So if you have doubt, my personal advice is either to do it more proximal and definitely at the proximal stent edge, as you explained, to correct longitudinal stent deformation, or completely skip final pot, because I'm afraid by ruining metallic neocarina, you actually push all that metal into the ostium of the side branch. So you have to redo kissing and then final pot.
Yeah, you're totally right. The last, I said pot, but it's exactly not pot. It's like a proximal touch, is what you say. Yeah? It's not as aggressive, as proximal to the carina. It's just to the proximal part of the left main, aorto-ostial junction and proximal part, not to get involved in the polygon of confluence.
Yeah, there are many more questions, so we definitely need another webinar. I would like to ask Nicholas for my final slides. I really thank you both for fantastic presentation. I think this is something that everybody can learn, real tips and tricks for daily routine life, and you are really experts in left main PCI, and we learn both decide when we need upfront two-stent strategy, but also how to perform it. So to conclude, elective two-stent strategies should be considered for complex or extensive stenosis of the side branch, difficult side branch access, or high risk of compromise. But of course, technique should depend on individual patient's anatomical characteristics and the operator's skill. We may prefer provisional stepwise approach ending up with T-tap or culotte, but also for operators with appropriate experience, DK crush is valuable option for complex left main bifurcations like in Mirvat case. I would like to thank both of you, but of course I would like to thank especially to people who made this possible, the Medtronic team and the Visible Heart team, Paul, Tinen, and Thomas. They organize and share this knowledge and experience is very valid and very valuable, not only for fellows, but also for experienced operators. So I would like to announce the next upcoming webinar on 7th of July, and it will be detailed description of common pitfalls in bifurcation PCI. I'm sure there will be a lot to learn also in the final webinar. I thank you all for your attention and thank you very much for joining us today. Have a nice day.
Hi. Thank you. Bye.